Granular appearance and immunofluorescence seen in post-streptococcal glomerulonephritis, diffuse proliferative glomerulonephritis, and antiglomerular basement membrane anti-GBM antibodies seen in good posture syndrome. Anti-GBM antibodies, good posture syndrome, granular appearance and immunofluorescence seen in post-streptococcal and diffuse proliferative glomerulonephritis. Next, normal anion gap metabolic acidosis seen in diarrhea, Addison disease, renal tubular acidosis, fistula, acetazolamide, ammonium chloride injection, ammonium chloride injection, and heterosigmoidostomy. Heterosigmoidostomy, ammonium chloride, acetazolamide, fistula, renal tubular acidosis, Addison's disease, and diarrhea. All these conditions have normal anion gap metabolic acidosis, raised anion gap metabolic acidosis, shock, alcohol poisoning, hypoxia, renal failure, diabetic ketoacidosis, salicylate poisoning. Everything, these are onions, so acids. So anion gap is raised in shock, alcohol, hypoxia, renal failure, diabetic ketoacidosis, salicylate poisoning. Next, metabolic alkalosis seen in primary hyperaldosteronism, diuretics, licorice, Batter syndrome, Cushing syndrome, hypokalemia, carbenoxolone, vomiting, aspiration. All these metabolic alkalosis. So, metabolic alkalosis, primary hyperaldosteronism, diuretics, licorice, Batter syndrome, Cushing syndrome, hypokalemia, carbenoxolone, vomiting, aspiration. Water deprivation test is for diabetes insipidus, ACTH simulation, ACTH stimulation test is for Addison's disease. Water deprivation is for diabetes. Next, Fanconi syndrome. Fanconi syndrome type 2, proximal renal tubular acidosis, rickets, osteomalacia, and polyuria. Fanconi syndrome, you can see type 2 renal tubular acidosis, rickets, osteomalacia, polyuria, Fanconi syndrome. Acidosis, renal tubular acidosis, renal tubular acidosis, Fanconi syndrome. So next, Cone syndrome. Cone is hypokalemia, hypokalemia, Cone syndrome, hypokalemia, and hypertension, potassium decreased hypertension, alkalosis, Fanconi syndrome is acidosis. Fanconi syndrome, acidosis. Cone syndrome, Cone syndrome is alkalosis. If you see alkalosis, you can eliminate the Fanconi syndrome. No similar family history, raised aldosterone. Cone syndrome, we can see raised aldosterone. Aldosterone is raised. And patient is hypertensive. This is also very important. Hypertensive and potassium is low. Hypertension and raised aldosterone. Alkalosis. Fanconi is different. Renal tubular. Renal tubular problem will be there. Renal. Acidosis and rickets. Renal and rickets osteomalacia. Renal. So polyuria. Renal. So everything is related to renal. Fanconi syndrome is related to renal. Cone syndrome is related to hypertension. Hypokalemia, hypertension. Potassium is favorable towards low blood pressure. Potassium helps sending sodium out. So, hypokalemia, hypertension. If we have potassium, potassium is good to reduce hypertension. So, here it is hypokalemia. Here it is hypokalemia. So, hypertension. And alkalosis, raised aldosterone. Next, generalized disorder of renal tubular transport in the proximal convoluted tubule. So, renal disorder in the proximal convoluted tubule is Fanconi syndrome. Next, immune complex IgG-MC3. All these deposition in the glomeruli means post-streptococcal glomerulonephritis. Immune complexes IgG-MC3. Next, a history of long-term anacid that is related to papillary necrosis. And granular muddy brown cast is related to tubular necrosis. Tubular necrosis, muddy brown cast. Long-term anacid use, papillary necrosis. If you see the urine is not clear, muddy brown casts are seen. That is tubular necrosis. Chromosome 4 is a Huntington disease. Chromosome 4 is Huntington. Chromosome 4 is Huntington. Huntington. Okay. Chromosome 16. 16 is chromosome 16 is autosomal dominant type 1. Autosomal dominant type 1 polycystic kidney disease 16, and half of it, if divided by 4, then it is autosomal type 2. Type 2 is type 2 is chromosome 4. Type 1 is chromosome 16. Chromosome 16 type 1. Huntington disease is type 4, type 2 disease, type 2, Huntington, type 2. And its involved chromosome is 4. These are papillae. This is renal papillary necrosis. This is renal papillary necrosis. Papillary necrosis, long term medication use and all. NSAIDs use, nephrotoxic drugs. NSAIDs, phenacetin, all those things. If it is tubular necrosis, muddy brown casts are seen. Here are mnemonics to help remember this. Post streptococcal glomerulonephritis. Hums. History of upper respiratory disease. So if you see history of upper respiratory disease, that is post streptococcal disease. So membrane deposits are subepithelial. Membrane deposits are subepithelial. Visualize humps as mountains formed by immune deposits. So good posture syndrome, good good lines, good lines, good line, good posture, good lines, good posture syndrome. So along the linear deposits along the glomerular basement membrane. So this is good posture. Alport syndrome, mutations in type 4 collagen and a basket weave appearance. Kidneys, ears, and eyes are affected. Okay, mutations in type 4 collagen. This is called Alport syndrome, and we can see a splitting of lamina densa that leads to basket weave appearance on microscopy. That is Alport syndrome. So, finding supportive of prerenal disease in acute kidney injury. Findings supportive of prerenal. So, basically, urea creatinine ratio more than 20:1, more than 20:1. Okay, and concentration more than 500. Concentration is more than 500 milliosmoles per kg, and sodium concentration less than 20 milliequivalents per liter. So, urine osmolarity is very important. Urine osmolarity is high here. Concentration is high. Urine osmolarity. Urine osmolarity. High. It is as important as well. Urine osmolarity is high. And high BUN. BUN is high. And sodium is less. And urinary sodium is less. Urinary sodium is less. Low sodium, low urine sodium, low urine sodium, low urine sodium, high burn, high urine osmolarity, high burn, high urine, low sodium osmolarity, and blocked sodium, blocked sodium, blocked sodium excretion. So it results in fractional sodium excretion is low. So sodium is low in the urine. Why? Because excretion is low. Excretion is low. So in the sodium in the urine will be less because excretion is less here. It is less than 1%. So, urine sodium is less than 20%, 20 milliequivalents per liter. Concentration, urine concentration is very high. Concentration is seen as osmolality. Urine osmolality is high. Osmolality is high, but the urine, uh, but sodium is less. Low sodium, high osmolality, high blood urea nitrogen to creatinine. So creatinine ratio. So creatinine ratio, urine urea creatinine ratio is high, very high, because blood urea is very high. So sodium excretion is blocked. Sodium excretion is blocked. Diffuse proliferative glomerulonephritis is associated with systemic lupus erythematosus. White loop appearance on a light microscopy characterized by subendothelial immune complex deposits seen on in electron microscopy. So white loop appearance on light microscopy, that is in diffuse proliferative glomerulonephritis in SLE. So granular appearance and immunofluorescence is post-streptococcal and diffuse proliferative glomerulonephritis. Apple green bifringence on Congo red staining, amyloidosis. Apple green bifringence on Congo red staining. Congo red and amyloidosis. Apple green bifringence. Next, wire loop appearance is diffuse proliferative associated with SLE. SLE. Thickened basement membrane with subepithelial electron dense deposits creating spike and dope appearance, membranous glomerulonephritis. Spike and dome అంటే membranous glomerulonephritis. Membranous glomerulonephritis. Spike and dome appearance. This is seen in cancers, malignancies, membranous glomerulonephritis. Next, C3 nephritic factor, membranoproliferative glomerulonephritis type 2 is called dense deposit disease. So membranoproliferative and C3 nephritic factor is present, and this is MPGN type 2, membranoproliferative type 2. Type 2 is dense deposit disease. Type 2 is dense deposit disease. 3Ds ఉంటాయి ఇందులో. Dense deposit disease 3D. So type 2 dense deposit disease. Stabilizes the alternative complement pathway leading to persistent complement activation. Thickened basement membrane with the subepithelial electron dense deposits. Spike and dome is membranous glomerulonephritis. It is present in malignancies and autoimmune diseases associated with the autoimmune and it is associated with autoimmune and malignancy diseases. This is so C3 nephritic factor type 2 membranoproliferative, it is a dense deposit. And thickened basement membrane subepithelial electron dense deposits. Spike and dome appearance. This is membranous nephropathy. This is membranous, not membranous proliferate or something. It's membranous. So it's not membranous proliferate. It's membranous. It is present in autoimmune diseases or malignancies. Few conditions. Membranous nephropathy seen in malignancies, autoimmune diseases. Subepithelial humps, post-streptococcal glomerulonephritis. Humps is subepithelial and that too subepithelial, that is post-streptococcal glomerulonephritis. Subendothelial immune complex disease deposits, subepithelial immune complex deposits. This is epithelial. This is epithelial. This is endothelial. This is endothelial. Okay. This is endothelial. So, seen in MPGN type 1. Epithelial humps seen in post-streptococcal glomerulonephritis. Endothelial immune complexes seen in MPGN type 1 DPGN. Subendothelial immune complex deposits with tram track appearance. MPGN type 1. So, tram track appearance. Subendothelial deposits tram track appearance. MPGN. Type 1. This is mesangial cell proliferation type 1. If it is type 2, dense deposits. Type 2 is a dense deposits. Type 2 dense deposits. Type 1 tram track appearance. Intramembranous dense deposit. Type 2 tram track appearance. Type tram track appearance. Type 1 dense deposits. Type 2 dense deposit. Type 2 post-streptococcal glomerulonephritis. Post-streptococcal humps, spikes, spike and dome. Lines, linear deposits, good posture syndrome. Dense, intramembranous dense deposits. Type 2. Tram track type 1. Tram track type 1. MPGN. Membranoproliferative glomerulonephritis type 1. Tram track. Membranoproliferative glomerulonephritis type 2 dense deposits. Lines, linear deposits, good posture syndrome, and spikes, subepithelial spikes, membranous nephropathy seen in malignancies and autoimmune diseases. Subepithelial humps is seen in post-streptococcal glomerulonephritis. Subepithelial subepithelial spikes, membranous nephropathy, subepithelial immune deposits. These are immune deposits. So immune deposits seen in these are immune deposits. So these are seen in post-streptococcal glomerulonephritis. So these are immune deposits. Immune deposits are seen in post-streptococcal glomerulonephritis. The spikes are membranous nephropathy. Lines are seen in good posture syndrome. Dense deposits. MPGN membranoproliferative glomerulonephritis. Type 2 Tram-track appearance. Membranoproliferative glomerulonephritis. Type 1 Tram-track appearance. Type 1 dense deposits. Type 2 renal good fangers and spikes. Spike endomembranous nephropathy. Humps are seen in subepithelial humps, that is post-streptococcal post-streptococcal glomerulonephropathy. Next, cystinuria diagnosis. Cyanide nitroprusside test. Cystinuria diagnosis is cyanide nitroprusside test. Cystinuria. Cyanide nitroprusside test.